notorious for forgetting that. So we are recording now. You should see something pop up on your screen. If you can just accept that, that would be wonderful. And again, reminder, use the chat if you have any questions. Let me make sure that we have everyone muted. And I will go ahead and turn it over to President Neely Bendapudi to officially get us started.
All right. Hello, everyone. Welcome. It's such a pleasure to have you here. Want you to know that you have to pardon my informality today. I walked around welcoming students and families that are back on campus. And when I got back, I was too lazy to change. I want to tell you that this is our special thank you to you. This is by invitation. We wanted to set up a forum for our board members, for whether you're on the trustees, the President's Council, EULA, Foundation, or just friends of the university that have supported us all these years. So one of the goals of this, and I cannot think of a better way to kick this off, is we wanted to highlight for all of you the incredible research that happens at the University of Louisville. I am so glad that we are kicking this off with what I think really showcases the best of the University of Louisville. I've told you that we are one of the top research universities in the entire country. We are R1. You all know Division I, Division II athletics, D1, D2. They have the same classification for research. We are an R1 university, about 130 across the whole world, you could say, because we include Canada. So that allows us to say that. And secondly, we are also one of now only 65 universities that are both very, very high in research and very, very high in community engagement. And I am known to my boss, Mary Nixon is here, Jim Rogers is here, Scott Brinkman, all of the people on the board that I report to. But I also see so many of you who are on the President's Council, on EULA, on others. So Jim Rogers is here. So thank you, all of you, for joining us. And some of you have heard me say this spiel. That was my apology. I want you to know that this project, you've always heard me talk about now, next, and beyond. That's kind of how I think about the world. What's happening now, what happens next, what happens beyond. And this particular project on the co-immunity project really is research with impact. Impact today, impact tomorrow, and impact in a sustainable fashion for the long run. So I will say more about Christina Lee Brown, or Christy, in a minute, but for now I want to acknowledge all of the people that came together to make this co-immunity project come together. I want to thank, of course, the James Graham Brown Cancer Center, the Jewish Heritage Fund for Excellence, Norton Hospital, Baptist Hospital, our own U of L Hospital, the Louisville Healthcare CEO Council, all for supporting this project that comes out of the Christina Lee Brown Envirome Institute. You will hear a lot more about the Envirome Institute and the incredible work that's being done here from two people from the center who will be presenting shortly. So with great thanks to Nancy Martin, that I just recruited Aruni here, give me the honor of introducing a very good person, an incredible professional colleague, but a good human. That's what I value incredibly much, Dr. Aruni Bhatnagar. So he is widely known. People, this is special. Many people are researchers that build on something, but Aruni Bhatnagar spearheaded this new field of environmental cardiology. And he is the Smith and Lucille Gibson Professor of Medicine at the University of Louisville. He has spent more than 25 years studying the impact of toxic substances, whether it's tobacco or environmental pollutants. What does it do to heart health? He is a graduate of Kanpur University in India. He received his postdoctoral training at the University of Texas, the medical branch at Galveston. He is known for his pioneering cutting-edge work on the metabolism of toxic substances and how they impact cardiovascular health. And this is so interesting to me, how the world we live in, the healthy soil and air and water, how they impact us, because he also studies how these factors contribute to diabetes. His research, oh gosh, this guy is super productive. Just reading about this makes me tired. He has published over 280 research papers. Can you believe that? And commentaries, 20 book chapters, and his research has been supported by NIH, the EPA, Department of Defense, the American Heart Association, and keeping people like Aruni here is not possible without the wisdom and generosity of people like Christina Lee Brown and many, many of you. So he currently serves as the director of the center that we have here, the Envirome Institute at the University of Louisville. He is also the director of the American Heart Association's Tobacco Regulation and Addiction Center. And the Envirome, when I was first presented with the idea, I could not believe my excitement. It resonated with me so deeply. The idea is just like we've studied the genes, and that's called the Genome Project. Why not study the environment and see what impact it has through the Envirome? And so without further ado, Dr. Aruni Bhatnagar. Come on, everybody, applaud.
Thank you so much, Neeli. I'm really overwhelmed. I think we should stop now before people find out the truth. So I think you have sort of really been a strong supporter of the Institute, and we could not have done any of this work without your support and your enthusiasm, your encouragement, and your cheerleading that you have sort of egged us on to take on this task. So I'm really grateful for the opportunity to talk to everyone here, but also most importantly, to be able to discuss our work. And I'm going to put up my screen up and show what some of the things that we have been doing. So I don't know whether I have it up, but just give me a minute. Can you see it?
Aruni, not yet.
Okay, I figured all this out, but I'm just going to get it done again. Okay?
Yes.
Okay. So what I want to do is to share some of the work that we've been doing in what we call the Co-Immunity Project. And in this project, we've been trying to understand what is the extent and the nature and the severity of the COVID pandemic in our community. And in order to do that, we first need to understand what is it that that's been happening in our community, how widespread the infection is, what are the rates of mortality and disease. And so for that, we need to understand how many people are actually being infected. So for that, what we did was we launched this Co-Immunity Project, which was actually in partnership with the Louisville Healthcare CEO Council, the Norton Healthcare, Baptist Health, the UFL Hospital in Nepalus. And with this sort of exemplary team, we came together and said that we must start a grassroots initiative to be able to understand and gauge the true impact of the pandemic in our community. So we started with different sort of long-term goals, and one of the goals, which is we call the phase one, which was done all here at the University of Louisville, at the Christina Lee Brown Institute, as well as the Center for Predictive Medicine. And we are particularly fortunate to have these world-class facilities, particularly the CPM, which has this BSL lab that is one of the 12 biocontainment labs in the country. So our first objective was, which we call the phase one of our study, was to look at the rates of infection in the community, particularly in the healthcare workers. The healthcare workers are the most important sector of our society, particularly during a health emergency like the COVID pandemic. And then we want to make sure that those individuals safe, that they were in the hospital doing, taking care of the patients, and they themselves were not in harm's way. So for that, in the last 3-4 months, we have recruited over 1,300 healthcare workers. And it was an interesting study. We asked them to test themselves, and we would give them little lancets to bleed themselves, so they get a little drop of blood in a tube, and then we would have them sort of do their own sort of swabs, and then deposit the samples to us. And so when we analyzed those, we found that a very low percent of those people, so we found about 6 people total over the 1,300 people who were positive at that particular time with the active infection. So what that means is that our healthcare force is very well, very careful, very well protected, and that the rates of infection are much lower than they may be in the general community. We did find several of our healthcare workers, about 34 of them, to have antibodies against the disease, which is against the infection, which would mean that they have been exposed to the infection and they have had the virus and they have recovered from it. And we are going to go back to them again in the future to test whether their immunity is maintained and what were the conditions that led to the infection, so that we can create a healthy, safe environment within our hospitals to be able to take care of our patients and the large number of members of our community who have been afflicted with this infection. We found that most of our healthcare professionals who were infected were either nurses, physician assistants, or respiratory therapists, and they were working mostly in the emergency department, in the ICU, or the hospital floor, and most of them were localized to a few areas. So we can then deploy sort of preventive measures to ensure that the rates of infection are lower in these facilities, and that we have our patients coming back to our healthcare facilities are safe, and the physicians are not being exposed to undue harm. So after we have done this, and it's not, like I said, it's not over, we're going to keep repeating that every 6 weeks, but at the same time, we also wanted to gauge what the level of infection in the community was. And the best way of doing that was to do sort of random sampling. And this is important because people who come in and say, I want to get tested, that they might already have reasons to believe that they've been infected, and that will skew the results. So as everywhere in the country, people have what we call convenient sample data, and this convenience sampling will skew the results, because the more you sample, the more people turn out to be positive. We do not know who and where the infection is at particular time. It only depends, because we test on only the people who show up. So we said, no, let us go to the people rather than have people come to us, and invite them to participate in a study, so that we will be able to understand clearly, rigorously, comprehensively, and readily what the level of infection is in Jefferson County. So for that, we look at the county, and as you can see, this city has different distinct zones with different sort of features of people who live in these areas. There are people living in this area, which we call 1A and B, have a sort of very high proportion of non-white residents. Only 28 or 45% residents are white, where at other places, the white residents could be up to 93, 91 to 86%. So because of this sort of different sort of demographics within the city, we wanted to ensure that we include everyone, that we treat each of these areas as an independent unit and try to get equal number or equal proportion of the people from that area, so that we don't leave everybody out. So this sort of technically is called stratified randomized sampling. And we have different areas that we sample. These are 4 zones of the city. We want to make sure that the number of sort of non-white participants that we have in our sampling is proportional to the number of non-white participants in that neighborhood. And also, we want to make sure that we recruit about a significant fraction of the total population. We want to make sure that their demographic distribution is proportional to that present in that area. We want to make sure that it's equal distribution of age groups also. So we want to ensure that people of higher age groups are represented as well as the people of other age groups. And then you want to make sure that our sex ratio is balanced. So once we have this sort of scheme, then we systematically can understand who may be infected and what the rate of infection in our community may be. So for that, we invited around 1,800 individuals, or 18,000 individuals from Jefferson County. We sent out 18,000 letters. In comparison with that, we got a low response. There were many reasons for that. The mail services were disrupted that time. There was unrest in the city, but whatever the reason is, we do not know. But we had but significant number of people responded. We had other volunteers who volunteered to be tested. So we tested over 2,000 people. And what we found was that these people belonged to all different parts of the city. So even when they self-volunteered, we ended up having a very good distribution of individuals covering different parts of Jefferson County. And yet, as you can see, that there were certain areas from which we get a lot more people than the others, but we have enough numbers to make some reasonable sort of inferences. And what we found that from the number of people we tested, about 0.5% of those were testing positive for the virus. Another 4% had antibodies against the virus. So we know that there is at least 4% of our population must at some point had been exposed to COVID-19. And if we sort of extrapolate that to the general population, we think that about at least about 20,000 people within the community may have been infected at one time or the other. So this number, that if we think 20,000 people in Louisville had COVID, is much higher than the number that's been reported in the city. We have only reported at the end of June 4,000 infections, which means that a lot of people either don't know that they had the virus, or maybe they did not get tested, or did not have the opportunity to get tested before they started feeling better again. Because we know in the earlier phases of the pandemic, there were all these restrictions, and there are still sort of impediments to getting tested to people. So we think that this study provides us with some clue of what the total spread of the infection would be. In addition, the study also tells us what the actual fatality rate would be. So we've been arguing about this in the literature, in other places around the country, saying if X number of people get infected, how many people will end up dying? There have been widely different estimates because nobody has done a random sample of people to correlate how many people were truly infected compared with how many people who actually died as a result of the infection. So we think that we have one of the best estimates available so far. And it shows that about 1.3% people who get infected actually succumb to the infection, which means that 98.7% people are going to recover and would not die as a result of the disease. But 1.3 is also a very large number. It's actually double the number that the CDC is estimating from their convenience sampling, which we think is biased. So it's an important number to know what the total sort of fatality or severity of the disease is. But in addition, we could also tell who was infected is where they were living or where they got infection. So as you can see from this map, that most of our infections were in this area, which is what we call the west end of the city. And in this area, about 70% of the population either is Black or brown. And so we have much larger extent of infections in these areas. And that reflects or is similar to experience elsewhere, where minority communities, underserved communities, vulnerable communities are much more susceptible to the infection and susceptible to succumbing from the infection than the majority communities. Which I don't have it here, but if you see the maps of how the infection spread over Louisville from March, we could see that the infection started here in the east end, with all the suburbs and rich individuals who traveled across the world sort of seeded the infection, and the infection then spread from east, and now it's all settled in the west. And so that would tell us that there are vulnerabilities in this area that have making these individuals highly susceptible to COVID infection. So we also found that the outcomes are very different. So about 1% of whites who would be infected die from the disease, whereas 2% of blacks or non-whites who get infections die. So the fatality rate is so much more higher in the black community than it's in the non-black community. And that is, to us, is disturbing. I think there's some work that we need to do in order to understand the nature of the disease, to understand the nature of the disparity of the disease, and then to try to figure out, understand, and develop new ways of overcoming these disparities so that there could be an equitable distribution, or not only of testing, but also of outcomes, so that we provide much more intensive care to the people who are actually more likely to get infected. We are going to develop or are going to have to develop treatments that would be useful to both and available to the underserved and to vulnerable communities. And in future, if the federal government comes out with vaccines or some other therapeutics, that those new diagnostic and therapeutic modes are available in an equitable fashion across communities. And so we want to ensure that our communities have the minimal levels of disparity that we can achieve. So with that aim, we're going to be able to, we should continuously monitor, we're going to do this again, how this will function, what type of things that we need to do in the next round, which we are starting in September. But in the meantime, we're also, in addition to doing a population survey, also looking at the wastewater distribution and how wastewater could then we should be able to tell is to get the rates of infection in the community according to wastewater. So I'm going to put this screen here in a minute. It changed. And introduce my colleague, Ted Smith, who has been working with me on this from the very beginning. He is an associate professor of medicine in our Christina Lee Brown Environment Institute, and he is a deputy director of the institute, and at the same time, the director of our Center for Healthy Air, Water, and Soil in our School of Medicine. He and Christy sort of started this Center for Healthy Air, Water, and Soil many years ago, and so sort of inspired all of us to get together in this collective initiative to be able to study the impact of the environment. And much before he was at the university, he was doing sort of studying these environmental influences. He has also served previously as the Chief Innovation Officer for the city of Louisville, and he created the largest real-time asthma surveillance research program, which is known as Air Louisville, and which has attracted sort of worldwide attention of how to look at the distribution of asthma rates around different parts of the city and to identify hotspots that trigger asthma attacks. Ted received his BS in biology and in psychology from Allegheny University, and his master's and PhD in experimental psychology from Miami University, and completed his postdoc studies at MIT. And we are very fortunate to have somebody like Ted, who's been involved with this from the very beginning. It's been an invaluable partnership, and I hand over to him to tell you about the rest of the co-immunity initiatives. So Ted?
Thank you so much, Dr. Bhatnagar. And thank you for bringing up the Air Louisville project. I noticed one of our attendees was one of our great collaborators, Dr. Jim Sublett. And so thank you for joining us tonight. Feels a bit nostalgic. So I guess Aruni is the straight man, because I'm going to now talk to you in the dinner hour about what I think is the most interesting work that we're doing in the co-immunity project, which is sampling wastewater in our sewer system. So I hope you've all had enough to drink and you're ready for this exciting chapter. So why would we want to ruin your evening with sewage? Well, there's a couple of really good reasons. You know, we've all witnessed this pandemic together as a group exercise. And so we've all sort of seen some of the trials and tribulations of our governments at every level, trying to respond, the university trying to respond. And I think we all learned a lot about the role testing plays in fighting this pandemic. And I like to use active verbs. We're fighting the pandemic. This is a part of the project that is very much focused on how we can actively contain and minimize the infection in our community. So the wonderful thing is we have this big randomized sampling project in the background, which is a gold standard for assessing prevalence of infection in a community. We're the only county in America that is doing this work. And it has created a great opportunity for us, and that is to hunt for other innovations that could really help us slow down this virus. And so I don't need to tell you, but the scarcity around testing and the inconvenience around testing, it's been a huge problem for our country. And we're probably not going to win if the only tool that we have to fight this is a nasal swab, because it's just too difficult to get to everybody. I mean, we've seen small countries like New Zealand aggressively make these attempts, or Iceland. But I mean, in our country, it's just not realistic to imagine we can test everybody. And if we can't test everybody, then we're going to have to come up with some other way to identify where infected people are. Now, you add to the complexity, and I think we all know this is a novel coronavirus. It's novel for a couple of reasons. One, we recognize that the fatality rate among the very young is low, and that's a wonderful and good thing. It makes it unlike past influenzas. And so we've learned that about it. Well, we've also learned that there appear to be asymptomatic and pre-symptomatic spreaders. And that, of course, is the terrifying news. And so the fact of the matter is that there are people in our community who aren't exhibiting the original CDC symptoms, and they're walking around unknowingly, potentially infecting other people. And so we have to take that part very, very seriously. And so in certain occupations, there's regular testing, because you can't have somebody working in a long-term care facility interacting with their residents who are highly vulnerable without having some assurance that even an asymptomatic person isn't in that facility. But once you get out into a community, it's a real challenge for us. Again, we can't chase people with nasal swabs all over the place all the time. So this idea of how will we sample the community. And if there's any way that we could do it that was then passive and was cost effective, well, that would just be great, because we'll spend, I think in this next piece of legislation, $16 billion on testing. And so if there is a less expensive, more reliable way to get this work done, I think we should all be trying to get that job done. So let me introduce you to your bathroom. So it turns out that one of the features that is absolutely a feature and a benefit of this particular virus is that it is shed through the human feces. And so, we're used to thinking about it as a droplet-borne transmission virus, which it is, but we also happen to know that in many infected people, we don't know the total number, but we think most people with the infection will shed it also through feces, which then gives us a gateway to detect the virus in this other channel. So the sanitary sewer system in a community turns out to be potentially a sentinel, surveillance infrastructure, if you will. And so what we do is we're able to, because everything's connected together by pipes, we know exactly, how many households are associated with what main pipe going into which water treatment facility. And we can work our way back to a framework of, can we isolate parts of communities all the way down to buildings in the case of maybe a homeless shelter or a long-term care facility or a prison. But today we're talking about what we're doing in our community. The Co-Immunity Project is about Jefferson County and really tackling a hard problem, which is community infection. And so at the community level, looking at that sewer system, and looking at it as an opportunity to have your finger on the pulse across different parts of the community would be a very, very powerful thing. And it turns out there are hundreds of researchers around the world right now working on methodologies for detecting the virus in wastewater. Now, we've been working with wastewater epidemiology at the Environment Institute for a year and a half now. We have another ambitious project called the Green Heart Project, where we were actually already in the sewer system trying to find evidence that people were breathing in air pollution, and that maybe they were urinating out metabolites, products that proved that they had inhaled polluted air. And so we were already familiar with and working with collaborators across the country on methods for how you work in essentially the sanitary sewer system. So we were ready, we engaged early, and because of the wisdom of the larger project, we were able to essentially attach this on and get all the benefits of the bigger project. And I'll make that clear in a second. But in case you're skeptical, and there are many people that are skeptical about using wastewater to, solve a public health crisis, this is a graph that was published by a team at Yale University a little over a month ago. And so this is on the left side in the red are copies of the virus detected in New Haven, Connecticut in their central wastewater treatment facility. And in the black line is cases that appeared in the healthcare system. And so you can see that there appears to be some temporal advantage, some leading opportunity that we can find it earlier in the sewage than we find it in the clinic. And it seems to, at least in the case of New Haven, it trended up along with the infections that came in the hospital, and it trended down as the infection rate went down in the hospital, and you had a jump of anywhere from 4 to 7 days. Now, the reason why we're not all reading about this all the time is because that was at a central wastewater facility, which essentially represented the entire population of New Haven, Connecticut. So you're just sort of documenting the interesting, I guess. It's close to trivia if you can't do anything about it, right? Because if people are going to get infected and they're going to get infected 7 days later, knowing about it earlier with nothing to do doesn't help you, right? So our project has this wonderful advantage of we've already sort of divided up the city into meaningful, discrete, different kinds of populations that we have reason to believe, if we had a good handle on what was going on in those different parts of the city, that we could potentially have some more regular measurement activity going on. So you can't see it easily in the slides, I'm sure, but there's green dots all over this. I believe there are 17 of them on this particular map. And those are locations in partnership with MSD where we are sampling out of the sewer system in the community. And that is then overlaid with all the wonderful data from the prevalence assessment Dr. Bhatnagar just shared with you, so that we can start to get some correspondence between infection rates in different places from that study, and then this more regular passive measurement. And so we've begun this work. We started in May with MSD, and we are sampling twice a week at these locations. You can probably guess one of the great advantages of working like this is that we're not chasing people down with swabs. It's a passive activity. Most people would have no idea, that we're able to glean this information out of the community. It's extremely cost effective. So the amount of money that it takes to get a copy of the virus out of the wastewater is exactly the same as the amount of money that it takes to get it out of your nose. So if we can get the collective infection rate of an area over time, and we see trending, we know that part of our community may be an opportunity for increased community testing. Maybe some of the social measures that we take, we don't need to take as a kind of a giant geography. Maybe we can make tweaks in places to respond to that early warning, and again, combat the virus. Now, it isn't all so good, too good to be true. I mean, there's some work that we didn't realize that we were going to have to be getting into, and I'll be thanking a number of people at the end of this, but let me just say, if it weren't for the Center for Predictive Medicine here at the University of Louisville, we wouldn't have had a team of virologists who, once we figured out that maybe we were hunting for the wrong part of the virus RNA, I mean, and by we, I mean the other 120 researchers around the planet, and we had the ability to then tune these assays. And Dr. Josh Fuqua in particular really saved the day for us, because he came up with a new methodology that we're now sharing with others around the country for better ways to isolate the virus in wastewater. The CDC and the EPA, they have initiatives. It's a little bit of the Wild West right now. And so thanks to the larger project, the fact that we have this, I think of it as a 1-2 punch. We're doing regular sampling randomly of the community, and we overlay that with high frequency sampling of wastewater. And together we get a very good picture then of what's going on in the community. So as you can guess, if you're not on a sanitary sewer system, if you have a septic tank or worse, we can't capture what's going on, your contribution, if you will. And so there are some tricks with how far you can scale an approach like this. But as a rule of thumb, if you've got more than 10,000 people in a community, you probably have a wastewater treatment facility in that community of some scale. And many buildings are big enough in the corporate side that they have their own facilities in their own campuses. So there's a great opportunity here, and it's a really exciting part of the project. Important to know that this is the building that never gets done getting built as long as we have a pandemic, I suppose. So Dr. Bhatnagar shared with you that there was a phase 1 where we started with the healthcare workers. Phase 2 is our expansion to do randomized testing in the community, adding in community wastewater. Phase 3, which will be starting soon, is bringing back folks who had tested positive in the past, and really beginning a follow-up with those individuals to get a better understanding. Because as you all know, there's a lot of controversy about the nature of immunity and how persistent it is, and all of those questions. We here at the University of Louisville have a tremendous opportunity to contribute to our understanding of that. And then, fingers crossed, we've had some tremendous partnership with the state, with Governor Beshear and Commissioner Stack. We are very optimistic that we will be able to expand this methodology into the state in a variety of capacities, but randomized testing in the state, as well as wastewater testing in some critical facilities across the state. And then, because that wasn't enough to do, phase 5 is working with ULH to open up a COVID survivors clinic, which, you might imagine diseases like this, sometimes come with long-term consequences. And, we do expect there will be people that will benefit from follow-up care. And so we will, through the University Hospital, provide a clinic for that care. And then it's time for the thank yous. It's always fun to be Dr. Bhatnagar or myself and pretend that 2 people do this massive amount of work. But here is a subset of our co-investigators who really have done some tremendous heavy lifting here. Dr. Rachel Keith, Dr. John Klein, who's also our Vice Dean of Research at the School of Medicine, Dr. Barbara Cave, Crystal Herminsky, Ken Palmer, who you heard about earlier, because he runs the Center for Predictive Medicine. Obviously, our team at the Envirome Institute broadly has been heavily involved. And then the Healthcare CEO Council and the other hospital executives in our community and their tremendous sense of partnership. And then to actually make it happen, this work wasn't funded by the federal government while we were still hunting for nasal swabs all around the country. And so if it were not for the bold and visionary leadership of several of our community foundations, including an ambitious and catalytic gift from the James Graham Brown Foundation, from the Owsley Brown Family Foundation, the Jewish Heritage Fund for Excellence. That was the beginning for us. It was a good shot in the arm. It helped us get out ahead of this early. We had the Foundation for Healthy Kentucky and Delta Dental, come in, and then a number of individuals, named right here on the slide, who also came in and played their part. As long as we have a pandemic, we are going to be doing this work. So maybe unlike a number of other research projects where, you say, well, this is what I'm going to do, I go do it and I write a paper about it. We are a part of active combat of this infection, and we will be doing this work as long as it is a threat to people in our community and in our Commonwealth. And so we always encourage support of any kind at any time for the project. So with that, I would love to hand it back to President Bendapudi.
All right. Thank you so very, very much, Ted. There are two things you all need to know about Ted. He's incredibly creative, came up with this co-immunity project idea, and he gets very, very excited about studying wastewater, in case you didn't realize that. I hope you saw how interesting this is, how novel it is, how we're helping, the fact that we can bring all aspects of the university together. But now, especially the Center for Predictive Medicine, the incredible work that Dr. Palmer and his team are doing. Again, we hope to bring many, many of these to you. But now it is my distinct pleasure to introduce somebody who truly, you say this of a lot of people, but in her case, it's true. I don't think she needs an introduction to any of you on the call. But it is my great pleasure and joy to introduce her. It is because of her that we have the Envirome Institute at the University of Louisville. She's truly dedicated. In all of my conversations with her, here are a few themes that emerge. She truly does believe in a new vision of health. And she's talking about health in a more holistic way that you can think about, that it's physical health, it's emotional health, it's spiritual health, truly what is human flourishing. That's what I think she cares about. The other thing that I love about Christy is that she's always talking about balance and harmony and how do we create that in our own lives and in the lives of those around us. And some of you may know that she truly does care about making a difference. It's not just about her, but really loves Louisville and thinks of it as the family that we need to rise together. And it is her passion and her vision that she brought to the Envirome Institute when this virus revealed itself in our Commonwealth and she was diagnosed. And she said, all right, I have these resources, I am going to tackle this, but what will happen to everybody as this spreads around? It's her understanding that Louisville needs to serve as a global model in researching the immunity, mapping the spread of it, and grasping the deeper effects of this virus. And I just want to say a sincere thank you to Christy, because she has brought, as I said, her passion, her vision of what we can do. And we are both a Research One university and a very high community engaged university. And you can see the value of that research right here in our community. So with that, I am going to turn it over to Christina Lee Brown.
Neely, thank you so much. I don't know if am I on the screen. Is that good? Is it working? There we go. Okay, thank you. Hello, everyone. Welcome to our urban laboratory and our University of Louisville, which is fortunately so willing to get itself into a place of serious, as you just have heard, of serious research, but willing to be able to take the kinds of risk to wade into the unknown waters, to really begin to help us each find out how in the world we can become a more effective part of the solutions that are needed in order to have much healthier individuals and much healthier communities. The university, I believe, is the most extraordinary platform for us to be able to do these kinds of experiments. And we want to welcome each of you for being with us. I know there are people from all over the country on this call, and that is a tremendous tribute to the University of Louisville, but really to your curiosity and to your understanding that you believe that we can each be a part of these much needed very, very difficult solutions. We've been having a lot of fun along the way as we work really, really hard, and we have been using this little circle of harmony and health as a tool. And Christy in particular uses it as a tool because, as many of you know who know me well, know it's very hard for me to attempt to stay focused. So this little tool of our circle of harmony and health allows me to be able to say to myself, but also to our project and to my family, are we actually looking at all these different forms of health and finding that we're making our decisions through these various forms? So to that end, we have started a curriculum called For the Circle of Harmony and Health, which you can find in the chat room on this wonderful Zoom call. And there's a link there, which I'm hoping that many of you might decide to sign up and become part of this pilot project, which is to help each of us understand when we do begin to think about making our decisions through the lens of health, maybe we actually are making healthier decisions and more helpful decisions. Neely said that I had been diagnosed, and that's true with the virus. And there were a number of us that were diagnosed with the virus who cared deeply about the University of Louisville and were involved in the Envirome Institute and its development. And that is, in fact, what got this remarkably internationally significant project going, is because we looked at each other and said, we must do something. We must figure out how to figure out. And so we got together the most extraordinary collection of new kinds of partners. Every major hospital in our community said, yes, indeed, we want to step forward and we want to become a partner in this unknown project. Every CEO, therefore, of these major hospitals, but also of the healthcare industry, stepped forward and said, yes, indeed, we want to become a partner. So we were formed it really was the most beautiful, and is the most beautiful example of individuals, of corporations, and now of governments deciding that they're going to partner in new kinds of ways in order to be the new kinds of solution makers. And I want to say to those of you that are not in Louisville, that maybe don't know intimately yet about this, to me, that is probably the greatest model of this project. And that's the model that we need to have copied in every major urban core to begin with, and then all around in the rural areas as well. But I do hope that you'll each consider joining us in whatever ways is appropriate for you, for your institution. But think also individually, possibly about joining us in this pilot project of using the Circle of Harmony and Health curriculum, so that together we can figure out whether or not we really can be the solution, and whether or not we actually can begin to make decisions through the lens of all these different forms of health as we're making our decisions in our everyday lives, in our work lives, in our political lives. So thank you so much. And it was a joy to hear the list that Ted read of the donors. It's been an honor for our family and I to be a part of it. We're all, as a group, so thrilled. And we're so excited about continuing this kind of involvement at this kind of level of creative research. So thank you, and I know now that you'll have lots of questions, and we want those because we want to learn from you and with you, and we hope that this is just the beginning of your partnership with us. So thank you.
Thank you so much, Christy. Good evening, everyone, and hello. My name's Elia Fox, and I'm the Executive Director of Development for the James Graham Brown Cancer Center, and this evening I have the privilege of being our moderator for the question and answer session. As a reminder, please type your questions in the chat box. We have a couple of questions already there to get us started, as well as questions that were submitted during registration. So first, how were you able to determine how the virus traveled from East End to West End?
So we got the data from the city of the virus infection rates from way back from March, and then we plotted the residence of the people who were infected every other week. So we got sort of a time series shot at the spread of the infections. When the infection first started in Louisville, we had only a few individuals in the East End who were infected. Soon then the infection moved in late March and April to South Louisville. And then it's sort of from there it went into the West, and then it stayed there, and it's sort of increased there. Whereas in the East, it is down to very low levels.
Can the wastewater be considered more holistically? There are many harmful viruses, other pathogens, and also maybe there are measures or indicators of positive health indicators.
That's a fantastic and highly educated question. So there is a whole nascent field called wastewater-based epidemiology. And the idea is very much that while some of us are excited about the idea of the gut microbiome and all the fancy testing that people get done now, what the sewer system is the collective gut of a community. And, anything that you could study in the gut microbiome, you could be studying in wastewater. And so there are many other pathogens that have been successfully isolated and identified. There are many pharmaceutical products that have been identified, so you can get a sense for, who's in the most pain, or, who's battling depression, it's kind of as a population, not as named individuals, of course. And then on the positive side, of course, to know when, healthy individuals have healthy patterns. And, if you think about something as simple as circadian rhythms and, whether people are getting enough sleep, and, when they wake up, they've got a little more cortisol. We'd see that in the sewer if everybody's waking up, at a healthy hour. So, the possibilities are endless. I know Dr. Bhatnagar is very interested in the work that we're doing in the Green Heart Project, and what we think of as beneficial volatile compounds that maybe trees and other plants emit and we breathe, and they're good for us. We would be able to see some of that also in the wastewater.
Yeah, the other interesting part is can give us some time resolution. So if you measure aspirin in wastewater every day of the week, the use of aspirin goes up on Mondays, and then it comes down on Tuesday. By Tuesday, it's half. By Wednesday, it's baseline. And you can see that in every community every week. So that's the type of interesting information wastewater can provide.
Dr. Bhatnagar, can you elaborate more on the national significance that you're finding? How are your results comparing to our global partners?
So we have not seen a whole lot of studies that have actually tried to get to the extent of the infection, despite all the resources, which I think is very surprising. There are very few studies that have done random sampling of the people to know what actual rates are. The only other study I know is from Indiana, and they had the same sort of problem with half the individuals that they invited did not come, and they did the entire state, and they sampled only 4,000 people for the whole state. So we did more than 2,000 people just in Louisville, and we're going to repeat that again. New York did a little bit in California, but they also had people invited from the sort of Facebook and other social media. So the importance of this is that this is to us one of the few studies which provides the true extent of infection within a community. It also tells us about the true rates of fatality, and to us local interest is where the infection rates are. So I think this is the type of work that we need nationwide to be able to get the grasp, because we keep hearing this. The reason we have greater rates of infection in Florida because they're doing more testing. Well, if you do randomized testing, the rates would not increase just by testing size or testing more people. So this gets across that argument. But I think this will be important, and this is how the studies on infection will be done elsewhere soon.
Another question for you both. What exactly is antibody testing?
So whenever we are exposed to a disease agent or a foreign agent, it could be a bacteria, it could be a virus, could also be some chemicals, that our body tries to defend itself. And in this defense, it makes these antibodies, which are like foot soldiers that go and find and bind to this invading particle or bacteria and then kill it. So that's our natural response. But these things take time. And so when people get exposed to a new virus like coronavirus that we have, is that they don't have antibodies or pre-existing antibodies to kill the virus. So what we do is we measure the levels of these antibodies, but once people have had the disease, they have antibodies. Like Christy had the disease, so she has really good antibodies. So she gets exposed again with the virus, she is ready for the defense. But most of us not, or most of us not been exposed to that. So that's why we need that. And when we give people vaccines, that's what vaccines do, is they provide and sort of they coax the generation of antibodies so people are immune to subsequent infections. Because once you have the antibodies, you have memory. But in this case, we do not know how long these antibodies are going to last. And that's one of our aims to study how persistent immunity is to COVID.
And how unique is Louisville's situation in terms of testing and speed of results? And is there anything that gives us a unique advantage?
So I can parts of that, and maybe Ted can want to add to this. We are a small city compared to other places like New York and London. But we have low rates of infection. We've had very low rates from the beginning, which we were very fortunate, but all that advantage has been erased in the last few weeks. We've seen our rates increase tremendously. Most surprisingly, the rates were between highest in the age group of 20 to 40. And so we are sort of peaking up again. And so therefore, we are back into the same position. In the last few weeks, we had some trouble in getting results back in time. In our study, we provide people results back within 24 hours. In some cases, within 8 hours, because like in hospitals, we don't want our physicians and nurses to be infected and be taking care of patients. So we want so the time is of the essence. So the sooner we do the testing, the sooner we report that to a person, the person can then quarantine and we spread the rate of infection. So I think we are unique in the sense that the problem here is still manageable if we do it right. And so far we have been doing it right. Right, Ted?
Yeah, no, I would say one of the great advantages of a community of our size, and I think it's a little bit special to Louisville, generally speaking, is, and I'll give President Bendaputi a lot of this credit. I mean, we've, I think, worked really hard to coordinate with the city, essentially merged city county, right? I mean, we have unprecedented collaboration with our county health department. And if you're fighting an infectious disease, you know, the flow of information is just as important as dealing with the actual substance of the disease itself. And so, you know, we have a remarkably productive collaboration, you know, with the city, and now a growing one with the state. And that's really helping us learn more quickly. So we're cycling through as we learn things and we can test them against other sources of information. Together we can problem solve. I mean, I don't see that happening in much larger cities. I mean, they're really, the lack of coordination compounded with the test turnaround times that the labs have and all these other problems that we know about. I think it's going to be one of our great strengths. I mean, we're never going to be insulated from the larger testing, you know, challenges that face the country. You know, and when the federal government's diverting resources from one state to another state, it's difficult to always know whether you're going to have enough test materials. But, you know, I think we're really trying to innovate our way out of this as best as we can, and I'm certainly be part of it.
Well, we are at the end of the hour, but we have two final questions in our chat. First, can you discuss any ideas on protests and infection increases?
Right, so there isn't much evidence here or elsewhere about the protests increasing the infection rates, but we do not know. Nobody's done a systematic study to do that. Our concern, as Ted and I have been talking about, is not so much the infection, but the tear gas. There have been some problems with the tear gas, and there was some complaints, especially in women who are exposed to tear gas, that it sort of interferes with the menstrual cycle and may have long-term effects on fertility. So we're trying to study that next because of that.
Mm-hmm. And our final question, any recommendations for the best testing cadence or protocol for groups looking to go back to work or back to school in large numbers, weekly or daily rolling tests, for example, and what combination of antigen versus PCR versus antibody testing?
For going back to work and to have people to be effective as with other people, we need PCR testing. Antibody testing is to cover past infections. It doesn't tell us much who is infected at the moment. So we need PCR testing and not antibody testing for that right away. And then we need to consider to have at least 10 to 20% of the pool of population tested randomly to be able to make sure that the infections are not there. There are certain, it's unfortunate that we don't have national directives, but a group of us as academics got together and we have sort of guidelines like if you have more than 1 per 100,000 infection rates, then it would be safe to go out open schools. If you have more than 5, then you have to have a different level of emergency. But testing, and it should be done every, I would say, fortnightly, every 14 days, every 2 weeks, if you want to test the entire population to make sure that the rates of infection are low. So, and I just can't end this without noting that, you know, in the last 16 weeks, we have had high rates of deaths. We have 1,000 people dying per day. And I think it's important that we are doing this And we're doing this work because we can't just let that go unnoticed and continue to pretend that this is business as usual, that so many people have died with this disease, and it's difficult for us to just stand on the sidelines. And that's the reason we are doing it, and that's why we should be doing this.
Thank you. Thank you, Dr. Rooney. Thank you both. So to close out our event, it's my pleasure to now turn it over to Dr. Jasmine Ferrier, the Vice President of University Advancement. Jasmine?
Thank you, Aaliyah, and thank you all for a really informative and understandable presentation that I think takes into account the extraordinary interest that lay people have in this ongoing struggle. I want to thank Christy Brown. Thank you very much. It was such an honor to meet you last week. Of course, I want to thank Dr. Bhatnagar and Ted Smith and all of the partners who have helped the Co-Immunity Project launch on such short notice and with such broad breadth. I also want to thank Marianne Vetter and the alumni team, as well as Aaliyah Fox, for helping to moderate. Everybody on this program tonight will receive a personal follow-up to give you an opportunity to support this important project that brings U of L very close to the lives and the health of our entire community, and gives us an opportunity to show what real research innovation means and how it can be scaled both bigger and broader for the entire community and beyond. Thank you, and thank you, Dr. Bendapudi, for being here tonight and helping us to organize this very important project.
Oh, thank you so much, Jasmine. I'm so glad you all got to meet the amazing Jasmine Ferrier. I am thrilled that she is leading us. I want to just say once again how glad we are you've joined us.
Thank you.
Let me see if I can do a participant gallery. How many of you familiar with Hamilton, right? The musical? Just know that you are in the Zoom where it happens. Never mind, I could not resist.
We're all going to steal that one tomorrow.
I just wanted you to know the work that the Envirom is doing, and this community project needs your support because we have to live with the virus. It's not going to go away. And the fact that you're with Aruni and Ted and as you heard, like Dr. Sublett was supporting this from the ASPA project. These are important. We're counting on your help. So thank you, and everybody, go Cards. I'm going to put up my circle of harmony and health right there, and go Cards. Bye-bye.
Thank you.
Thank you.
Thanks, everybody.
Thank you.
Thank you.
Thank you all.